All right, it's ready to go.
All right. Good afternoon, everyone. Thank you all so much for being here, both students and practitioner alike. We're going to be, Max is actually the first one to kind of be a part of this series where he's going to be sharing, where some of our partners are going to be sharing a little bit about what it is they do and their roles. And then there'll be a chance to kind of ask some questions and, kind of do a little mini networking session to see maybe this is something you're interested in exploring as a field or maybe even potentially as an APE opportunity and stuff like that. Max, I should have wrote you up a very formal introduction that kind of highlights your dopeness and who you are. But Max is an alumni of our program in the epidemiology concentration, correct?
Correct.
Epidemiology concentration. I mean, it's funny. I was like, well, yeah. I mean, he graduated like a couple years ago, but I'm thinking a couple was closer to like
It's almost 10.
five or six, yeah, almost 10 years ago. So no, Max a really long time. He's doing some amazing work over at Prisma Health. And he's just a really great guy too. So was really excited when he kind of reached out about wanting to get back and share with the students kind of some of the work he's been doing. So without further ado, I'm going to turn it over to you, Max, to share your story, share what you do for work, and yeah, maybe have a great discussion here. So we'll get you shared, and yeah, let's make it happen.
Sure. Thank you for the introduction. I'll go ahead and share my screen. Um, I was hoping to be able to use the chat box a little bit while I was talking, so give me a second just to open that up. I'm just curious for everyone on the call, are you all current students right now? Yeah, pretty much everyone's a student. If you wouldn't mind just like maybe putting in the chat box what program you're in, I'm just curious kind of where everyone's stacking up nowadays. Um, Seeing where the numbers kind of lie. HISPUM, nice. I know I had a good group of people in the EPI program, but I think HPEB has always been the biggest kind of driver. So I was curious to kind of see if that is holding up. EPI, my EPI folks. Oh, a bunch of EPI folks. That's cool. Well, welcome. I'm gonna get my screen back up. Thank you again for that introduction. My name is Max Habicht. I am an infection prevention partner here at Prisma Health Richland. It's one of the big community hospitals. It's over on that Hardin Street extension. If you've ever driven by that big hospital as you're getting on the interstate, that's where I'm working. I am an alumni of the Arnold School 2 times, actually. I graduated with my undergraduate BA in public health and also my master's back in, I don't remember. I have a slide with that information. We can get to it. But my objectives kind of for this talk today, I don't think we'll go the full hour. I think I have about 30 minutes of content. Just to kind of introduce myself, kind of talk about my time in the program at the Arnold School, and kind of introduce the world of infection prevention to you all, because when I was in school, I don't think I really had a good understanding of what this field was. Granted that it's changed, I guess, in the past 5 years or so. I think this field got a lot of got a big highlight with the COVID pandemic. So maybe you have heard about it, but I know that during my time in school, I didn't really have any clue about it. So just trying to kind of bridge that gap between you all and talk about kind of my role here now as it fits in day to day, and then hopefully talk to you all about potential chances to collaborate, maybe work on a project over the summer, because I know you all will need to do some practicums, and we've got a lot of good opportunities here at the hospital, a lot of good data, and it would be just a good experience, I think. Oh, I also have a couple slides at the end. It's an outbreak activity, if we have time permitting. That's kind of what I like to nerd out on. We don't have to get to that, though. It just depends if there's any questions or anything. I do not have any financial disclosures. So I already mentioned I'm a 2 times graduate of USC, 2016 with my BA, 2019 with my MPH. So you're right, Zach, it's been about 6 years. When I was there, I did a practicum with, I don't believe she's there anymore, Dr. Suzanne McDermott, and it was focused around childhood lead exposure and impacts sort of on their neurodevelopment when they get into that 5, 6, 7 year age range. After college or after grad school, I had my first job at the South Carolina Department of Health and Environmental Control, which is now known as the Department of Public Health. I worked there for about 4 years. I was in Epidemiologist 1 and 2, and I worked in the Healthcare Associated Infections program. And that was my introduction to really I worked with a lot of the infection preventionists around the state. I had a really unique job where I was interfacing with them pretty much every single day. So I had a lot of experience working with the personnel in hospitals throughout the state and kind of just got my foot in the door here at Prisma Richland, and that's kind of what led me to this job here. I've been in this current role for about a year and 3 months, and I like it a lot. Okay. I don't know if you guys are very familiar with infection prevention, but I wanted to provide a brief history. There's about 12 bullets. It's not very brief, but just to sort of demonstrate how kind of new and how this field is evolving and maybe sort of gauge some interest from you all, and maybe you'll be able to see the direction that it's headed into the future. So in 1946, the CDC was founded. It was called the Communicable Disease Center. Now it's obviously a Center for Disease Control and Prevention. And the primary task back in 1946 was field investigation, training, and control of communicable disease, plus the encouragement of a formal infection control program. So in 1946, infection control and prevention was not even a thing. They even encouraged it, but that doesn't really take hold, you'll find out, for about 30 to 40 more years. In 1951, the Joint Commission was founded. TJC is kind of like our governing body in healthcare. It's what serves out all of our accreditation. So that's been in existence for about 75 years. And we interact with them a lot on a day-to-day basis. So I guess the governing body was founded really quickly. However, the actual people doing the work that would be reporting to this organization weren't really there yet in terms of being full-time employees. In 1965, CDC initiated the Comprehensive Hospital Infection Program. It was known as CHIP, the acronym. You're all in public health. You know we use acronyms for everything. This program included 8 community hospitals across the country, and it served as the basis for the development of modern surveillance and infection control techniques. Moving forward a little bit, in 1970, CDC established the National Nosocomial Infection Surveillance System. It's no longer called that. Now it's called NHSN, the National Healthcare Safety Network. It's still in existence today, and that is the program that CDC funds that we as infection preventionists and epidemiologists, we report all of our disease statistics to. In 1972, the first professional infection prevention society was created. It's called APIC, the Association for Professionals in Infection Control. I'm a member of that currently, and I will plug that a little bit later, so just stay tuned for that. 1974, CDC began a national study known as the Study on Efficacy of Nosocomial Infection Control, or SENIC. If you're not familiar, nosocomial is just another synonym for means hospital acquired or hospital associated. So this was 1974. SENIC was a study that included 338 hospitals throughout the country, and they basically took half hospitals that had infection prevention programs and half hospitals that did not have infection prevention programs, and they compared their disease statistics. Lo and behold, the hospitals that had IPs on site we're doing a lot better in their prevention of disease transmission. And that was in 1974. So we're steadily working towards where we are today. 1976, Joint Commission established their first accreditation standards for IP. And I think that's kind of where they've been operating since then. So since 76, about 50 years, they've been that source of accreditation for all hospitals. 1980, the first education standards for IPs were created. So this is almost 50 years after the encouragement of infection prevention programs, right? So it's taken a little bit of time to get off the ground. We started having education standards back then. 1991, the U.S. Department of Health and Human Services, oops, that's a typo, established the Hospital Infection Control Practices Advisory Committee, or HICPAC. This committee provides guidance and advice to the CDC regarding practice of infection control and strategies for surveillance, prevention, and control of HAIs, antimicrobial resistance, and pretty much any sort of associated transmissible event that might happen within a hospital. In 1999, the Institute of Medicine published a report. It was called "To Err is Human," and it revealed thousands of patients were dying each and every year from injuries that they might have acquired while within the hospital. So this is kind of our first real shift towards hospital-associated infections and really seeing their true impact on patients. This is 1999, so it's pretty recent, right? 2002, states began to mandate healthcare facilities report their HAIs to the public. That is exactly what I used to do in my old role. I was that person that would reach out to these infection preventionists and the hospitals and say, hey, we need your data. We're trying to publish our yearly report. Technically it is a law, so don't make me invoke that, please. But you are required to report X, Y, and Z as it comes about. 2005 to 2006, there were 2 research projects that were published highlighting central line associated bloodstream infections, or referred to as CLABSI. I'll talk about CLABSI in a little bit, but just trying to highlight that we're slowly getting a little bit more forward thinking on what causes infections and what are our modern day HAIs, or hospital associated infections. In 2010, Congress incorporated HAI prevention into the value-based purchasing program of the Affordable Care Act. This was the first law that made HAIs mandatory to be reported, and that first one that was absolutely mandatory was CLABSIs throughout the country. 2013, CDC publishes antibiotic resistance threats in the United States, and that report estimated that more than 2 million infections and 23,000 deaths per year in the United States are associated with antimicrobial resistance. That incurs a direct cost of over $20 billion to the healthcare facilities and the patients themselves. So this is 12 years ago. This is where we see sort of another shift that we're kind of currently living in, and the topic is antimicrobial resistance. And then in 2019, there was the SARS-CoV-2 pandemic, and now I guess we are kind of still riding out that pandemic. But I think it was kind of a jump starter, a kickstarter to improvement throughout the world of infection prevention. We learned a lot of good things in it. There was a lot of challenges, a lot of burnout, but ultimately, you get through the fire, you come out stronger, right? Let's backtrack just for a second. So public or infection prevention wasn't really a thing, right, until the maybe 1970s or 1980s. But that doesn't mean that the theories, the thought processes around it didn't exist, right? Germ theory was a thing. People knew you get sick. They didn't just necessarily know why you get sick or how you get sick or how to get better, really. Remember back in the day, some people thought that you could cure disease by bleeding one another. They would cut themselves open and they thought losing their blood would cure themselves. Anyway, in 1846, there was an Austrian doctor. I can't pronounce his name. I'm going to call him Iggy Semmelweis. He coined the phrase or the condition childbed fever, and he was working in a hospital and he noticed an increased mortality in their newborns in the birthing clinic. And he did a little investigation and he noticed that there were medical students that were working in the morgue with cadavers, and then they were just going right across the hall into that birthing clinic and helping deliver these babies, and they were getting sick and they were ultimately dying. This was in 1846. So this kind of helped demonstrate the direct disease transmission, and that ultimately led to a lot of improvements in terms of hand hygiene. And I think he actually implemented this program at his hospital where he required anyone working in that morgue that day, they weren't allowed to do anything directly patient facing the rest of the day. If you were in the morgue, if you touched a dead body, you had to either stay there for the day, you had to go home before you could come back and work with the infants. In 1854, Florence Nightingale was working in the Crimean War, and she was able to demonstrate that hygiene is important for the outcomes of wounded soldiers. She put a really large emphasis on using clean linen, not just reusing bloody whatever gauze and bandages they need to do to treat these soldiers. Being able to clean the areas that they were holding these wounded soldiers, that had a lot to do with whether or not someone was going to recover quickly or ultimately have an infection that might ultimately cause their death. And I don't know, I wasn't able to find a date on this one, but Joseph Lister was a British surgeon, I believe, and he demonstrated that limb amputation infection was much more likely without hand hygiene and antiseptic treatment prior to surgery. And so these are, I guess, kind of the pinnacles of infection prevention that we still follow today. Hand hygiene being the big one, aseptic technique, being able to properly prepare the body if you're going to do something incredibly invasive. And that was probably also around the 1860s. So these thought processes have been there. There just never really was an emphasis, a need to put that in any sort of formal program until, I guess, in the 1970s, 1980s. So what is the role of IP? I sort of just talked a little bit about the timeline of it and some of our early thoughts that led to where we are now. But if I had to put it into one sentence, and how this is how I tell people who aren't familiar with the field at all, the role is to break the chain of transmission, break the chain of infection. If we notice a couple patients in the hospital that have the same disease and maybe they're like right next to each other in the hall, it is our immediate priority to try to break that chain of transmission, trying to get out of a potential outbreak scenario, because that can just be like a wildfire, especially in a hospital setting where a lot of people are really sick. Breaking that chain of infection can be more or less difficult depending on the factors involved. For example, the size of your hospital, the capabilities of the hospital. For example, Richland is a very large hospital. We have about 600 and something beds, and there are about 100 or so discharges every day. So that's 100 or so new people coming in. And that's not even counting the people that are treated just in the emergency department and go home. It's a level 1 trauma center. So there are a lot of people that come in via ambulance, get a lot of emergency surgeries. We also have a children's hospital attached to it. There are a lot of children oncology patients. So that's a very special population. We also have a heart hospital, a lot of operating rooms. We have a large on-site laboratory that handles all of our on-site microbiology testing. And then we also have a behavioral health hospital. It's on the campus, it's not directly attached, but still there is some crossover between those patients. So breaking that disease transmission can be kind of challenging at times. But luckily, since we have such a big facility, we have a good team here. We have 5 people on my team. So the general rule of thumb in infection prevention is to have about 1 full staff, full-time infection preventionist for about 100 to 110 beds. So we've got 600 something beds. We've got 5 people on our team. So we do a good job, cover each other, help each other. Just we have a collective goal as a team. Changing a little bit now towards, I guess, epidemiology. I'm guessing since a lot of you are in the epi program, you are very familiar with this image. This is the epidemiologic triangle, and it sort of demonstrates the interaction between a host, a pathogen, and the environment, and how that sort of contributes to whether or not a disease is able to survive and be successful. So a host is someone or something that is susceptible to a possible pathogen. The host can get sick, or sometimes they can be asymptomatic. They can just be a carrier of disease, but the takeaway message is they have to be able to allow that pathogen to sort of thrive within them or on them. The pathogen is obviously a disease-causing agent, such as a fungus, a bacteria, a virus, protozoa. And the environment is the conditions surrounding both the host and the pathogen that promote disease, and that includes factors like temperature, and in some examples, like accessibility to medical facilities. That is a really big factor in whether or not an environment can sort of incorporate disease growth. Some good examples I like to think about when you're trying to look at the 3-pronged approach of the epidemiologic triangle would be like HIV. Our agent or our pathogen in that example is obviously the virus. Our host is humans or chimpanzees, where a lot of researchers think that virus sort of derived from. And the environment can be a variety of different options. For example, whenever there are large pride events, we're likely going to see a spike in HIV incidence after that. And sort of on the flip side of that, areas of the country where there might be a lot of poverty or low access to good medical care, maybe in a specific community, there's a big stigma on seeking treatment for what people quote as like a sexually transmitted infection. So these are environmental factors that might deter someone from seeking care. Now, as we look at sort of our modern day HAIs, we have sort of 2 buckets of thought. We've got our reportable healthcare associated infections that I prefaced back, that took place in the early 2000s that was required to be reportable. And then we've got sort of our other quote unquote reportable things. Consider them more like common diseases. Like if someone were to have influenza, technically you can have a hospital associated case of influenza, but in terms of reporting these HAIs, we are looking at things that involve people where they might have undergone an indwelling or a very invasive procedure. So we've pretty much got 6 different types of hospital associated infections that we as IPs perform surveillance on. Our top 2 are going to be what we call device associated events or HAIs. They are catheter associated urinary tract infections or CAUTI and central line associated bloodstream infections or CLABSI. If you're not familiar with what a central line is, I threw this slide in last second just to sort of demonstrate that. It's generally a tube inserted into a large vein, typically in the chest area. They can be in like your jugular, your subclavian area. Sometimes you have them in like the bicep to the arm or in your groin. And they're going to advance that tube all the way up till it terminates pretty much right at your heart. And this is a way to provide long-term access for people if they need a lot of infusions, blood transfusions, antibiotics. This is just a more secure way rather than sticking someone peripherally like each and every day trying to give them drugs that they need. This is a really more permanent type of way. However, it is susceptible to infections as it being an open hole in somebody's skin. Some of our other reportable HAIs are ventilator-associated events, and that is whenever a patient is on a ventilator and they develop an pneumonia. That's kind of my bread and butter. I'll maybe talk about that a little bit more. And then we have surgical site infections. That is referred to as a procedure-associated infection. Here at Richland or at Baptist downtown, there are, I don't even know how many hip surgeries, knee surgeries, heart surgeries every single day. And these are patients who are at risk for surgical site infections. And those can occur weeks to months after the actual surgery. So it's really important that we're keeping tabs on them. We're practicing really good aseptic technique, hand hygiene, etc. And then our last 2 aren't really device or procedure associated. These are kind of fading into that antimicrobial resistance field. So we are tracking our Clostridioides difficile infections or C. diff and our methicillin-resistant Staphylococcus aureus or MRSA. These are kind of the most common bugs that we see in the hospital, and those are kind of directly transmitted patient to patient through. I mean, they can be fecal matter, it can just be direct touching, it doesn't really matter. So they're really dangerous. These can spread like wildfire. In today's data, or I guess 10 years ago, 2015, as it relates to HAIs, it's estimated that 1 in 31 patients will acquire an HAI. So I said at Richland, we have 600 beds. We're moving in and out about 100 to 200 people a day. That means about 9 to 12 people on average are going to have a healthcare associated infection. 3% of hospitalized patients will have 1 or more. So just because you have 1 doesn't mean that you're safe from all the other ones. If anything, I think it means it increases your risk of getting another infection. 75,000 hospital patients with HAIs will die during a hospitalization. Doesn't mean that their death was directly related to that specific infection, but I can definitely tell you that it does impact their level of care and their sort of ability to recover. I'm sure you guys have learned people with comorbid conditions are at much higher risk of developing who knows what than someone who might be quote unquote healthy. And finally, these HAIs accrue about $28.4 billion annually in excess healthcare costs. So it's a really big topic. It's a really big financial burden, both on the hospital and the patient. And sort of some of my role as an IP is tied to kind of saving our hospital money or not cutting corners, quote unquote, but trying to find best avenues forward to, 1, provide the level of care that we need to for the patients, being safe, being economical, but also, we're trying to save money. It is a business at the end of the day. These are kind of the core job functions I would say that infection preventionists fall under. I just tried to list off as many as I could sort of off the top of my head, just to sort of demonstrate that we're not, it's a really unique field. We have our hands in a lot of different buckets. We do a lot from day to day, and not every day is the same. So a big function of our job is surveillance. We are tracking these disease rates throughout the hospital. We do that day in, day out. We provide that data to our executive team. Decisions are made based off this data, and that data also goes towards our accreditation and sort of like our funding, our long-term funding. It drives our performance metrics. We do direct patient observation. Anyone with a central line or a Foley catheter, which helps them urinate, we are rounding on those patients, trying to make sure that the maintenance bundles that we have set in place are being followed. That means keeping the central line dressings clean, making sure that they are not like full of blood or debris, because blood and debris is kind of like a breeding ground for bacteria. So if you pull blood out of somebody's central line here and you leave blood in their valve, their access valve, that increases their risk of developing an infection. Next time that you pump something into that central line, that you might just be sending that organism directly right back into their bloodstream. We are very involved when it comes to construction or renovation projects here at the hospital. A lot of nasty stuff happens when construction occurs. There's a lot of dust, there's a lot of debris. So when you go in somewhere and you just sort of ransack a space, you tear down walls, you're up in the ceiling, you're working in the piping, the plumbing, it takes a lot of extra work to make sure that that space is safe and clean once it's intended to be used for patient care. So we are at the table sort of from soup to nuts, right? From the beginning of a project all the way to the end, we are there step by step, checking off, signing off, right alongside with the contractors. And that's really fun. You get to wear a hard hat, makes you look cool. We also are involved in policy creation and maintenance. We pretty much write a lot of policies as they relate to anything within my scope of infection prevention, whether it be hand hygiene, central line maintenance, Foley care. There's too many to name. Our big bread and butter is this policy that we have is called the disease specific table, and it is pages on pages on pages of diseases that a patient might come into the hospital with or get while they're here, and sort of the criteria on how we need to treat those patients, whether or not they are truly infectious, how do we isolate them appropriately, and sort of how can we get them off of that isolation, because no one wants to live on isolation. It makes everything more difficult for the patient, for the care provider, so on. We also provide a lot of data and statistics. Every day I'm auditing charts, I'm looking at our rates, I'm trying to improve our performance from bedside nursing to our providers. There's a lot of data analysis. It's pretty interesting. I already mentioned we handle the isolation precautions. We are involved in special projects, which I'm hoping to talk to you all about a little bit more in the next couple of slides. So put a pin in that one, special projects. We also do some outbreak investigations. That part's pretty fun too. You probably have learned about it a little bit in school, about sort of just outbreak investigation in general. If you have questions about it, I'd be happy to answer. But just for an example, we did a little bit of some contact tracing today. We had a patient last week who actually was diagnosed with Candida auris. That is a very difficult bug to treat. It's really prevalent in like nursing homes, skilled nursing facilities. So when patients are coming in and out from nursing homes, that's a very transmissible disease. So we were able to identify a couple patients throughout the hospital that were actually have used a bed that this sort of index case had, and we had to go today and initiate some screening protocols for them. We could talk about that a little bit later. We had to educate the staff. We had to tell them, what they needed to do in terms of swabbing, how they interact with the patient, to tell them that this is just a screening protocol, blah, blah, blah. It's good stuff though. We're very involved in emergency preparedness as well. So for example, if somebody is traveling out of the country and say they are flying back and they're a resident of Colombia or somewhere nearby, Maybe they get sick and while they're on the plane flying back from, I don't know, Africa or something, and they have Ebola or another type of hemorrhagic fever. Um, you can't just bring them to the emergency department and say, they're sick. Can they be admitted here? How do they get better? Right? That's a very dangerous disease, or those are very dangerous diseases. And it takes a lot of planning, a lot of care to sort of handle it appropriately. So we are involved with, there are people that work here specifically who are emergency managers, and we have developed a very big plan. And it's basically a blueprint, right? If someone were to roll up in the front door exhibiting XYZ, who are the people that need to be involved um, in order to sort of initiate this process? What is the specific route throughout the hospital that we're going to take? Where are we going to hold them? What room are we going to put them in when it's ready? How are we going to handle the waste that they create? So there are a lot of moving parts, and we are very involved with that planning process. We also do a lot of product evaluation. Um, Products, I don't even know how to talk about that. We change products, it seems like every 3 months. So we're going out, we're surveying the staff, the bedside nurses. We're trying to see what are they comfortable with, what do they understand in terms of how to use a product effectively. Then we take that back to the purchasing people here at the hospital. And ultimately, we're trying to find that sweet spot between what product is going to be best for the patients while also going to be the most affordable for the hospital. So that's a pretty fun part of the job as well. We do a lot of training and education. So public speaking is a big plus. If you're good at public speaking, if you're good at connecting with people, that is a good skill to have if you are interested in this role. We talk pretty much day in, day out with the bedside nurses, trying to educate them on best practices. If they have any questions about how they can better treat their patients, if they have a specific type of disease or infection, we are their resource. And then finally, we coordinate with the local and state public health departments. I pretty much get a call every single day from someone over there, and they're calling to ask about whatever. We're trying to um, just perform general surveillance on patients because these are people that live in our community, and sometimes they need a little bit more follow-up. For example, if someone has tuberculosis, um, they can be cured here at the hospital, but that doesn't mean that they're necessarily cured for life. So it relies on the partnership between people here at the hospital and our state and local health departments to kind of maintain that care going forward for these patients. This is a funny cartoon that I always throw in all my slides because this is kind of how I view the world. Not the world, but the hospital in general. So every single person is dirty, quote unquote dirty. You can see there we've got that guy, he's labeled as support staff. You got your administrative staff. There are different lines of people that you're going to be interacting with as a patient and as an employee here that all kind of drive your risk of infection, right? If you shake a hand of a stranger in a lobby and then you don't do hand hygiene and you go up and you touch a patient on the floor, you might get them sick with something. Just I want to demonstrate that the hospital is a dirty place, and you may think it's clean. And for the most part, we try to make it clean, right? But there are a lot of different factors here that drive sort of disease transmission. So who is the IP? How do you get into this field? This quote here at the top is kind of what led me to reach out to Zach in the first place. I was reading an article that said it was evaluating infection prevention programs throughout the country, and it had a line that said 40% of the current IP workforce is going to be eligible for retirement within 10 years. So if you sort of think back about that timeline, IP programs weren't really sort of kicking into gear until the 1980s, maybe the 1990s. So the people that sort of got in at that time had probably been working for about 25, 30 years in this field, and it's probably about their time to retire. And that is 40% is a large percent of employees. So we're going to be facing some challenges in the next 10 years. People that have previously been in this role, it's been dominated by nurses, right? You needed to have an RN, a registered nurse degree or whatever certification in order to even get this job. That mindset has changed starting in about 2015. I think everyone knows in public health, it's always best to have a multidisciplinary team, have people with different experiences, different skills all at the table. You got your stakeholders, and that is sort of the guts of a successful program. So starting in about 2015, that mindset started to shift away from only allowing nurses and sort of opening it up to other public health fields. So on my team, we've got 25, I think, different employees throughout the state. And we've got the majority of them RNs, don't get me wrong. But we've also got a couple of MPHs like myself. We've got people who were previously respiratory therapists. We've got some people who have PharmD degrees. We've got microbiologists, and all of us work really well together, sort of bringing our different experiences and our different skills to the table. Because when I started this job, I didn't know anything from a clinical perspective. I walked into a room, I was completely overwhelmed. I didn't know what anything was. I'd never been in a hospital before. Versus on the flip side, when I was doing like some basic surveillance and data analysis, and I was working with one of my colleagues who has been a nurse for 30 years, I sort of like opened up her view on how to do that more effectively. So that's just a testament that getting that broad background of experience together, and that really sort of drives the success that a IP programs would have. So be thinking about that. 40% of the workforce is going to be retiring in the next 40 years or next 10 years. That's a lot of open jobs for maybe people potentially in your shoes right now. Some skills that I sort of thought that are marketable if you are interested in the field of infection prevention is the ability to be flexible and learn new skills. I'm sure that you all have that. It was my experience while I was in the Arnold School in the Epi program that you sort of have these classes, right, that are trying to get you to learn very broad concepts. And it's kind of the same thought process when you're an undergrad. You're learning very broad, non-specific things. That way, when you get into a scenario, you can sort of pick and use whatever skills that you have and sort of customize it and apply it to whatever you need, right? So those are good skills to have if you're working in IP. You can take examples from whatever background you have and sort of think critically how to get the job done. Having that large knowledge base. I always tell people that I know a little about a lot. That's partly true because I am also, people see me as the subject matter expert. So there are certain things that I know a lot about. I can talk your ear off about pneumonia if you want to know more about that. But in general, I would say I know a lot about a little. Public speaking ability is also a plus to have. I wouldn't say I'm the strongest public speaker, but just being open to communicate with people and try to connect with people is a really big skill to have. Also, it's important to be passionate about the job. If there's ever times that I'm feeling sort of down, I just try to remind myself that like the people who I'm interacting with today are the people who live in my community. They could be my neighbors. They could be, I don't know, someone, I don't have any kids, but like maybe my kid's teacher or something. These are people who they live in my community. I am involved in their care and I want them to improve the same way. If I were to ever be in the hospital, I would want someone to care about my improvement rather than just viewing it as a job. And then lastly, this is something that I always find humorous. When talking about IP, people are always just assuming that like I am a germaphobe. I know everything about germs, and maybe I know a lot about germs, but I'm definitely not a germaphobe. I like to say that I'm germ aware. I can look at a surface and maybe assess its risk compared to a surface that had just been like wiped down with a disinfectant, but it doesn't mean I'm necessarily a germaphobe. I'm just very aware of what dirty things can do to healthy bodies. Here are some infection prevention resources if you're interested in sort of learning more generally about it. I included all the links on these slides. I'm sure we'll send these slides out if you want to click these. First is for APIC. There's a national site, and then we also have a state chapter called APIC Palmetto. It's got its own website. It's a great program to get involved with. We do a lot of education. We offer a lot of training, free training, and our website just has a lot of good free resources if you're interested. There's also the Society for Healthcare Epidemiology of America, or SHEA. This was an organization I was really involved with in my previous role, it's not as directly involved in infection prevention. It's more so for your academic side of epidemiology or maybe that state local health department side. Infection Control Today is a really good website that is um, managed by infection preventionists, and they just sort of write opinion pieces on whatever topic interests them, but they put out really good content. And then finally, there's the American Journal of Infection Control, or AJIC. This is where you're going to get more of your research topics, pretty much your more academic side of infection prevention, if you're interested in that type of stuff. Now sort of starting to conclude, I just wanted to try to rope in kind of my experience at the Arnold School and in the EPI program, and sort of how that might have led to this current job that I'm in now. I can't see the chat box anymore, but I saw that a bunch of you were in the EPI program. When I was in school, the four main groups were kind of EPI, biostats, ENHS, and HPEB, and I realize now that I left off HISPM, so I apologize to that person in the chat box who's in the HISPM program. But we had at the beginning, we had a lot of interaction across those different programs. We took a lot of the same classes, and it was really good experience to see sort of the different thought processes of these different people as they were interested in these different fields. And then sort of once you get your general classes down, you kind of are on your own with your EPI program or your whatever ENHS program, and you're doing your very specific classes. I really liked that. I think my curriculum might have been a little bit different than it currently is at the Arnold School, but I think it did a really good job of providing that broad background of skills and sort of thinking. And then once you sort of develop what you're really interested in, maybe you're working on a project towards graduation, you can sort of look back and draw on those skills that you learned in your first 2 semesters of the program and kind of put that to work however you need it to work for you. So now I just wanted to talk a little bit about potential projects. With speaking in Zach, I see we say we in the colloquial sense. We, as in Prisma Health, I think have an existing partnership with the Arnold School, and we are hoping to have sort of a student project this summer coming up. So on this slide is sort of an example of a project that we recently did in the past 6 months or so. This did not have any student involvement. We just did this internally, but I think it would be a really good example and offers some really good experience from the student perspective. So our project was centered around blood culture contaminations. At Prisma, we have sort of 2 markets. We have an upstate and a Midlands market. And within those upstate and Midlands market, there's about 6 or 7 different hospitals. So we've got about 13 different facilities spread across the state of South Carolina. We even actually have one in Tennessee now, but that's recent news. And we noticed that we had a high blood culture contamination rate at some hospitals compared to other hospitals, and we wanted to sort of dive down that hole and see why. So your threshold for blood culture contamination, the gold standard, is kind of 3%. Anything above 3%, you might indicate that you have a problem. So our overall goal was just to reduce blood culture contamination across the Prisma Health system. And we did that sort of with a 2-pronged approach. We wanted to identify the leading causes of variation in the collection process, and we wanted to standardize our products and our processes. So we had noticed through doing some observations that all of our different campuses were, 1, using different products when they were collecting blood cultures, and 2, they were doing a different process. So there was really no way to compare them directly, because ideally we would all be doing the same thing and you can sort of see what the glaring differences are. But we had a lot of work to do. We were all doing different things with different products. So what we did for our project is we were able to enlist 5 volunteer campuses. We picked 5 different campuses throughout the state, a couple big ones, a couple small ones that would match in terms of like patient populations. That way we could compare them. And we did direct observations of when blood cultures were being collected. We developed a specific procedural checklist as well as a product checklist. And we did a lot of education with the people who were going to be collecting these blood cultures on how they were supposed to be following this new procedure that we had made for them. It didn't differ much from the one they were using, so there wasn't real much need for more education. And what we did is we just went out and we observed them and we marked down if maybe they strayed from that process, if they elected to not use a certain product that had been provided to them. And then we went back and we tallied up all those results and we created a Pareto chart and we analyzed some of our other demographic information. And we were able to see sort of what we deemed as our low-hanging fruit in terms of what specific steps in that process were the staff members likely to defer from. And maybe we were following their results of their blood collection, and then that way following all that back and being able to point directly and say, maybe, you didn't do your antiseptic scrub for the intended time. Instead of doing 30 seconds, you only did 10 seconds. And then lo and behold, you had a blood culture contamination. So really trying to shine the light on the specific processes, the specific steps of that process, and really trying to drive home that these all have an impact. It's not just boxes that you have to check off when you're doing a certain task. They are set in stone for a reason. These are really important tasks. And ultimately, our results helped us change policy and drive policy. And we've since pretty much standardized throughout our system here. So that was just a general example. I mentioned that I was really interested in pneumonia earlier and ventilator and associated pneumonia specifically. However, a huge topic of conversation in the IP world is non-ventilator hospital associated pneumonia. So I just put this generally on a slide. If you're interested in working in a project like that, maybe the goal is to reduce non-ventilator pneumonia across Prisma Health, and we can fill in the methods and results how we want to do that. But I think working on a project here would be very beneficial. It will give you experience with some direct observations. You can pretty much plan an entire project yourself from birth to death. And you can get real boots on the ground experience. And yeah, that's kind of all I had here. So just to conclude real quickly, I'm trying to plug infection prevention because I know that we're going to be lacking in the next coming years. And I think it's really important being someone that came into the field without a nursing background. I can see how beneficial it is to have people from different experiences. So people coming directly out of grad school are kind of like a great population to sort of plug this to. It's a really great job. It's really versatile. Every day is completely different. You get to interact with a lot of different people. But there are chances to work individually, right? I can
Your mic went out, Max.
Oh no.
I heard you.
You're good. Okay.
You can still hear me?
Yeah, I got you.
Yeah.
I didn't cut out for me, so it's working.
Okay. Sorry about that. I think I was just sort of wrapping up saying, it's a good opportunity to work here. It's a fun job and it's super fun. When I meet new people and they ask me what my job is, I say infection prevention. And they say, what's that? And I say, I'm an epidemiologist. And they're like, what is that? So it's really fun to confuse them. My family still doesn't understand what I do, and I've been doing it for about 5 years. Does anybody have any questions? That was all I had. I said I had 30 minutes, but I guess I went for about 50.
Yeah, Carrie, I have a quick question.
Go for it, Naomi.
I had, so I was wondering, within the infection prevention, position, did you have to take the, CIC exam, the certification for an infection control exam?
I don't have it currently. It is expected that I am to get it in the next year or two. So I guess it sort of just depends maybe on who would be hiring you. I think it's a plus to have it, but I don't think it's necessarily required. Eventually it would be though, if you were to work here. Everyone I know who's been here for more than 5 years keeps up with that and they are certified.
Gotcha.
And
It's a good
well, you got another one, Naomi?
Yeah, I was wondering, within your graduate program, did you happen to publish research? What I've been kind of contemplating whether that is something that I really need to pursue to kind of increase my career opportunities, or was that not something that you did in graduate program?
That's a good question too. And I'd be interested in the perspectives of the others on this call, but I think it kind of just depends on what you're interested in going forward. Like if you are curious in pursuing academia, I think that is beneficial to you to sort of get your name out there and start publishing and like kind of proving that you can work in that research environment. I did not publish anything when I was in school other than my practicum project, which it didn't get published by anything like major. I have been involved with a couple projects since. They're pretty clinical. But no, I did not do any research, any direct research that led to a publication while I was in grad school.
Thank you.
I will say though, on
You guys have any
on
projects that
sorry, go ahead.
I just had like another random question about just like MRSA in South Carolina, if there's any like ongoing projects on that. But
Did you say MRSA?
yeah, the antibiotic resistant methadone resistant staph.
I'm sure that there are. We don't have anything specifically going. I mean, if you're interested in that, I know I put a non-ventilator pneumonia, but really I think it would be interesting to see, like, if someone were to come work with us for the summer, what are your interests in terms of your topics from school and sort of how can we meet in the middle? Because I can throw a bunch of different suggestions at you from my side, but if that's not something you're interested in or familiar with, I don't think it would be that beneficial. So if you're interested in MRSA, we definitely have buttloads of data that we could probably provide for a project.
So I've seen Mossy trying to hop in, I think, and Daniela's unmuted too. Great questions, Naomi. Thank you for that. So either one of y'all can chime in.
Hey, Max. Can you hear me?
Yes.
Oh, okay, perfect. I just want to ask you how is the collaboration, your collaboration as an IP professional with nurses, doctors, administrative staff? Do you feel that an epidemiologist and their opinion is kind of respected on that board? Because you said you're a team with other nurses and a microbiologist. So how do you feel as an epidemiologist on that position?
I like it. That's a really good question too. I interact with a lot of different people every day, whether it be bedside nurses. We work really closely with like the infectious disease doctors specifically at the hospital. But I do have some interaction just from like the general attendings who might be on the floor when we just need to talk about general patient things. Some nurses are a little wary of you. I'm not going to lie. They tend to be like the ones who have been working in nursing for a while. They don't really trust, the younger person that, what's an epidemiologist? What do you know? I've been a nurse for 35 years. But you can sort of draw back on your skills on being able to connect with someone and sort of demonstrate that you do know what you're talking about. And you're not necessarily like speaking down to someone or being condescending. You're trying to partner with them. And I think just coming in with like a positive mindset is beneficial. And I would say for the most part, I do feel respected by pretty much everyone I work with. But that goes two ways, right? So I try to show them the respect that they deserve as well.
Perfect, thank you. And I just wanted to ask you, like, what are some challenges that you face on your everyday work?
I'd say the biggest challenge is just knowing what the heck is happening from day to day. And that sounds bad, but I'd never been in a hospital until I started working here. So on the very first day I walked in and, everyone's using jargon. Everyone's been working here for years. They know what the sort of go-to process is. So they're using jargon to communicate with one another. And me coming in from the outside, I had no idea what they meant, what they wanted me to do. So I had to ask a lot of questions. And I don't think it's kind of like a general rule of thumb. We joke about that you're not going to be even a novice IP until about 2 years in the field. Pretty much your start to 2 years time, you're very inexperienced. Every day is really different. But I think having that as a skill, some people, if they don't understand something, they might tend to like shut down or feel self-conscious about that. But I think it's really beneficial. If you don't know something, just ask a question. Like nobody thinks you're quote unquote dumb for it. You're just trying to understand. And for the most part, people people like talking, they like educating others. So if you're open to learning new things, they will be able to educate you. But that's my
Thank you.
biggest challenge for sure.
Thanks so much.
Masi, you want to get in here? You have a question? I thought I seen your mic go off a couple times. Yeah, I see that you were gonna ask something, so go ahead while we wait on Masi.
Yes. So I was just wanting to know, in infection prevention, are there like opportunities where like you don't have like patient interaction or like interaction with like RNs or physicians or something, or is it like is it something where you always have to interact with them regarding the position? If that makes sense.
It does make sense. And I think it really just depends on the setting that you're working in. Um, like you have Prisma, which is a 600 bed acute care hospital. But there's like, we have an IP at Park Ridge Hospital, which is down towards Irma a little bit. And that's a really small, more of like a long-term care hospital. It's got about 60 beds. So it's not pretty much anyone that has a more intense need that goes to Park Ridge, they get sent here to Richland. So his experience in IP is completely different from mine. I'd say it's a lot more, I don't want to use casual, but like just different problems. You know, it depends on the setting that you're in. We also have other people on our team who are ambulatory IPs. All they do is work with like your urgent cares. So there's not as much direct interaction with like doctors or nurses for them.
Okay, that makes sense. Thank you.
All right, I think Masi, we have time for one question because Max starts charging us by the minute overtime after 5 o'clock. So, what question do you have for Max? And then I'll kind of wrap this all up and maybe like some next steps. So go for it, Masi.
Okay, I just want to ask about the potential project of non-ventilator hospital-associated pneumonia. Like, okay, would that be like a secondary data analysis, or would you be conducting a cohort study? How are you thinking about that?
I'm sorry, I had a little trouble hearing. I heard something like secondary analysis.
Yeah, I would just like to know how would the data be collected for that study? How are you planning to collect the data?
Well, that's an interesting question. I have sort of started, I guess, a project. Not I haven't gotten anywhere. It's mainly just conceptual thought at this point. But we have a giant electronic medical record that we use. It's called Epic. And we've got people on the back end who are sort of their Epic analysts. They write back end code, they create reports for us. And they would be able to, you would look at what the case definition was for non-ventilator hospital-associated pneumonia. And then within Epic, you can look at all the different variables that are collected for patient care, whether it be like, you know, just generally thinking like their temperature, their level of pain, blah, blah, blah. And you can sort of pluck and pull those variables to build a report depending on what you need. So for non-ventilator hospital-associated pneumonia, you need someone who's been in the hospital for greater than 48 hours. They're not on a ventilator, and they have like typical signs or symptoms that might be associated with an aspiration or a pneumonia. So it's typically like a chest x-ray. Maybe they have like difficulty swallowing, something like that. So we would be able to engage our Epic analysts to help us sort of build a report. And that in turn would help us sort of see our current incidence at the hospital. And then maybe we can estimate like a more longer term prevalence of it, but I think it would be pretty much like a primary gathering of data like that. Does that make sense?
Yeah, sure. Thank you. How can we like get in touch?
I just put my email in the chat box if you wanted to reach out to me, or
Okay.
Dr. Zach can probably help facilitate that.
Yeah,
Okay,
absolutely, everyone. First off, I just want to give Max a huge thank you for just paying it back and we're paying it forward, I guess, and giving back to the school, giving back to the students. This is the kind of experience that in these kind of interactions, this is why you go to graduate school. You know what I'm saying? To meet with partners, to work on innovative, interesting ideas. and just really cannot thank you enough for being willing to share with our students. I found the presentation immensely interesting, and I've learned a lot. And I will say this, I'm walking away feeling very excited. And I think this is a juncture where all of us, any type of good public health excitement, we can use some good news type thing. So I'm walking away feeling very excited at the prospect of maybe some of y'all collaborating with Max and doing some really cool projects. So just want to thank him from the bottom of the School of Public Health's heart, from everybody here. And also want to thank all of you for attending, just on a whim, or just being here, because these types of events, when our partners give here, I love when we can actually get people in attendance. So the partners may want to come back. And Max, you got to be careful. You might be getting picked up for like a clinical faculty role if you keep up those kind of lectures. So you got to watch out.
Don't tease me.
So I'll be in touch with we'll have this recorded, obviously, and share some of the slides and stuff like that. But don't be afraid to reach out to him directly, or if you're kind of interested in maybe pursuing an APE over the course of the summer or so, let me and Max know, and we can kind of get into the weeds more of what that could look like. Because as you all know, this is an art and a science, and the projects are living, moving things, and we got to capture all what that could look like. But thank you so much, Max. Really enjoyed all of this, and it sounds like we'll be in touch again soon.
Thank you all. I appreciate it.
Thank you.
We'll see y'all.
Thank you.
Bye.